Welcome back to another episode of Backtable OBGYN. I've got with me once again Dr. Amy Park. Amy, how are you today?
Great. How are you, Mark?
I'm good. And we have our first repeat guest. Very exciting. Once again, Dr. Barbara Levy, good friend and colleague of ours, clinical professor of OBGYN at the George Washington University School of Medicine and Health Sciences, voluntary clinical professor, UCSD, Department of OBGYN, of Obstetrics, Gynecology, and Reproductive Sciences. That's a mouthful. Barb, how are you?
I am great. How are you?
I'm good, and welcome back.
Thank you.
So, Barbara, can you tell me if I have this correct? So my understanding was it doesn't matter connected or not, doesn't matter physically. If a hospital, years ago, hospitals lobbied, because the hospital lobbies are like one of the biggest lobbies in DC, that our work is harder. We're taking care of folks with no insurance. And so we do all this extra work that doesn't get paid. So we need more money for the same work as somebody who's in a clinic somewhere.
Yeah, it's not really about work. It's about cost. So we have to have an emergency room that's open 24 hours a day. We need to have an MRI machine. So hospitals argued that they were required to have all of that availability, which was true back in the day when they didn't own all of these freestanding practices. But what has happened is they realized they could bill for a facility fee when patients were seeing us in independent offices. Yeah, the hospital they rake it in.
So what happened was, and this happened to a lot of my buddies coming to med schools, they would join practices. Hospitals would buy the practice, and for the same brick and mortar buildings, for the same MRI, CT scan, lab, whatever, now that the hospital owns it, they can charge hospital prices for the exact same thing. And so all these practices that are getting a nice check from the hospital to be bought out, there's a delta between what the doctor can make and what the hospital can make, and they come somewhere in between. The doctors are happy, but now everybody works for hospitals. And more importantly, patients that could pay an outpatient copay for ultrasound were being charged far more for an ultrasound machine that was in the exact same room 10 minutes ago. And so hospitals are making more money, but they're making it on the backs of the patients. It's like, yes, it's better reimbursement, but like at what cost? And who's paying the bill? The answer is kind of all are, but especially our patients.
So if we think of things like hysteroscopy or endometrial ablation, what does it cost a patient if we do it in a freestanding office versus an ASC or a hospital or a facility? The patient will pay an office copay if it's done in the office, $25, $35, whatever it is. All of a sudden, if it's in an ASC or a hospital, now she's got a percentage payment of the total cost, and it's $1,000.
What about if that hospital owns the clinic?
It depends on how the hospital bills it. If the hospital bills it under the hospital TIN, the tax ID number, then she's in essence in a facility.
And is the ASC the same as an OR? Because we've talked about that too. Like it's physician-owned ASCs versus hospital-owned ASCs. Does that matter?
That doesn't matter. So the ASC has a facility fee, whether it's owned by physicians or it's owned by the hospital. But the patients pay a lot more if the procedure's done in an ASC than if it's done in a true outpatient office.
What about ASC versus hospital?
Usually the ASC is paid less than a hospital. In fact, it's always paid less than the hospital. So the outpatient fees will be less than if you bring the patient to the hospital. And that makes sense because ASCs don't have ERs and all those kinds of things.
I just want to circle back and say what is really being, I think that like in the grand scheme of things, and this is just a more philosophical, like high level, big picture view, is that yes, the patients are suffering, but it's not really hospitals or physicians who are leveraging this on the patient. There's so much data coming and stories coming out about what insurance companies are doing. They figured out during COVID, hey, we don't have to pay for the knees or we don't have to pay for this. And then this, third-party AI-powered system that analyzes how you can leverage more patient payments for third-party, out-of-network providers or whatever.
I think that's a whole nother Backtable episode. But if we think about, again, I'm old. I've been around a long time. There were no pharmacy benefit managers. It's a total new industry that takes dollars away from physicians, facilities, and ultimately patients, right? And employers.
And the independent pharmacists. I mean, they're really,
So we've got layers of things that have happened over the last 30 years that add costs to the system without actually adding value.
So we have a lot of hands in the pot.
Yeah, the United thing, that United payer
Change Healthcare.
Yeah.
Yes.
That was horrible. We didn't even know about it. I didn't know about it.
I feel like Barb will also have to be our third time guest to talk about insurance companies. And no, I mean, Amy, there's nobody who knows more. It's amazing. But I think,
we have to always follow the money, right? Who's making money? Who are they for profit? Are they serving their shareholders? Are they serving? So that's with the private equity owned practices. We have to think about that. My focus is always on the patient and the physician, because that's where my heart and soul is.
I want to advocate. And this is where I think we come from the same school, Barb. Part of my interest, and now that I'm doing much more administration, yes, there are ways to learn these things to make money as an institution or whatever. But honestly, when you hear that it takes 17 years from a seminal paper being published to actual change in practice nationally, whereas if you just change the reimbursement on a procedure, overnight, you can impact how care gets done. And so to me, the value in this is about understanding the system well enough to know which knobs to turn, know which incentives to drive to get the actual care that you want. So there is a way to learn about this stuff to use it for good instead of evil. And I think what I want any listener who's interested in administration and healthcare economics and those things, this is not just about telling people to work harder and sleep less. It's about understanding how the system works so you can use that power for good instead of evil. And so that's what I've found is the most powerful way that I can impact patient care and outcomes is to learn as much as I can about the system. And so that's been the most helpful thing for me.
I couldn't agree with you more. I mean, Barb, you basically personify this, which is, I think I powerfully believe in the inside game. I understand the outside agitation, and there is definitely a role for that. However, if you really want to be effective, having a seat at the table and knowing how things work and how to leverage these seats of power, how to pull on those levers of power, I think that is truly where big change comes through. And understanding the incentives, those are powerful. I mean, look at office hysteroscopy. That incentivized and shifted a lot of the DNC hysteroscopies from ASCs and hospitals to the office. I mean, the hard ones, yeah, of course.
And it doesn't just have to be nationally. You can do this at your own institution in your own practices. But Barb is here not just to talk about the whole big world, but we also want to use examples. So this is an episode that Serena's sponsored for us, and we want to make sure that we stay on task a little bit. But to talk about an example, that's one example, but doing an outpatient procedure and how that, can we walk through that process of how that's different for patients, for payers, for all those things? And let's use that as an example of endometrial ablation, how that changes where you do it, and how that impacts both the physicians, but also the patients.
Yeah. So we talked a little bit about if it's done in an office, it's more efficient for us as providers most of the time, and we get paid more. So we get some practice expense payment that covers some of our overhead. So not only does it cover the cost of the equipment that we're using, but there's an increment for the use of our staff and the use of our space and all of those things. So payment is always going to look higher in the office. Interestingly, for cryoablation, CMS has called it a instrument-intense procedure and has increased the payment to ASCs substantially for cryoablation. So for people who have their physician-owned ASCs, their payment's going to look better in the ASC because the facility fee they get is going to be so much higher.
And who determines that? The insurers?
Well, CMS determined it, and now it's we're trying to get all the commercial insurers to understand that and follow suit, which they typically do. So for the patient, though, there's a higher cost when you go to an ASC because the patient's insurance, their health plan covers procedures in the office differently than they cover procedures in an ASC or a hospital.
Right. Single copay of a certain amount versus a percentage of total cost of services.
Correct. That's correct. And so for a patient, it makes a big difference. And if a patient has a high deductible health plan where they're paying the first $5,000 or $6,000 of the fee, it's a difference between maybe a $3,000 cost versus a $6,000 or $7,000 cost.
So pushing procedures that we can do safely to the office can provide massive savings for our patients. But the other thing that I think a lot of us realize is that I can do a hysteroscopy in the office between, in 5 seconds, between patients. The turnover time, waiting, it's an hour and a half. If the hysteroscopy takes 5 minutes in the OR, all that setup, takedown, and forgetting cost alone, my time has value as a surgeon. To be able to do that procedure in 15 minutes in the office, the work RVUs for me are the same, whether I'm doing it in the office. And so for those of us who don't own ASCs, who don't own our own practices, who are surgeons at big institutions where we're paid on an RVU model, getting away from the facility fees alone, if you can move a procedure to the office, you've just saved yourself an hour and a half for some of these minor procedures, office cystoscopy.
If you look at the efficiency, it is remarkable how much more you can get done. And it, again, as you point out, even if your practice is owned by a health system, so your patient won't do as well financially, but you will, because you will be so much more efficient. When we think about, you don't have to write orders, you don't have to, and if you can do a procedure in the office without IV analgesia, so you don't have to recover a patient in a recovery room and you don't have to have an RN to oversee that patient. And from a patient's perspective, remember that if we go to an ASC or a hospital, patient has to have a pre-op with anesthesia. Patient has to get their labs done. They
have to have a person with them to drive them. It's 2 people taking a day off work now.
There's a lot of burden on patients, and patients feel much more comfortable coming to our offices where they know where to park and they know where the bathroom is and they know your staff. And it ratchets down that sense of adrenaline, that sense of fear of the unknown, which is really a good thing because people do better when they're less anxious.
And Serene's done in the office. We've talked about this before. Remind us, remind our listeners.
Yeah, so Serene is cryoablation. And I've always been a fan of cryoablation, although I didn't love the older technology, because when you think about it, freezing is numbing. We put an ice pack on to numb nerves. And so for Serene, the only discomfort for the patient is putting in a speculum, which is not comfortable, and inserting a 5.5 millimeter tube.
What's a Mirena, for example, to compare?
It's about the same as it's the same as the Mirena in terms of diameter. So it's no bigger than that. Is that uncomfortable? Sure. Do I think paracervical block, if you know how to do it well, is a good thing to do? Absolutely. But once the device is in the uterus, there is no pain, right? It's a slow increase in pressure of a liner and then nitrous oxide. And so you're freezing the lining. You're not releasing all of the prostaglandins and the cytokines that heat releases from tissue. None of that gets released. So post-procedure, patients don't have the same day or two of severe cramping and pain. They don't have any of that.
Can they drive themselves home? Do you recommend they come with somebody for those?
If they need an anxiolytic, they need somebody to drive them home. If they're chill, for me, placement of a Mirena is more uncomfortable than the cryoablation procedure. So because post Mirena placement, people have a fair amount of cramping. Not everybody, but many do.
I was trying to get it with my new job. I'm not around enough to So we started looking at it. I think it's something we should try to get because I do think there's a huge desire to have that.
I think
OR
it's
time
a real
is
service.
well, getting OR time, so we can go on for another hour about why gynecologic surgeons have a hard time getting to the OR when you're talking about how much hospital makes on services compared to other specialties. If there's a way we can offset and offload some of those procedures to the office, our patients, yes, we can get them done sooner, but our patients can get care sooner. Oftentimes, if we can do those things in the office. And so there are ways to offload some of the things we do in the OR to get us to allow us to get to the OR to do these things we have to be in the OR for. Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _Backtable OBGYN on Instagram, Twitter, or LinkedIn. Backtable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich and Lindsay Beecham.
Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on Backtable OBGYN are their own and do not reflect the views or positions of their employers or any entities they represent.